Hi, and welcome to our first episode of Handover with Dorky Docs. And today we've got a very special guest, Dr Miesha Virdi, who's currently a post-CCST orthodontist in London. Now, Miesha and I are here to discuss a very sort of special relationship between doctors and dentists that often has quite a lot of banter there as well. But more importantly, what we should be able to learn from each other. But before we begin, and to introduce our first guest, who's got quite an impressive list of credentials that I've actually had to write down. Miesha went to university at the University of Birmingham to do her dentistry degree and then did her dental foundation training in Yorkshire and Humberside. Performed her dental core training in West Midlands before going on to her specialty training in Dorset and the South West, where she undertook her doctorate as well at Bristol. And now, as recently as last month, she's now an ST4 in London. Have I got that all right?
Yeah, that's really good, actually. Very impressive.
Perfect. I can take a break there. But how do you feel now that you know there's a light at the end of the tunnel of all that?
It feels amazing to think we've gone through so much and there's only a little bit more to go. I would say I would say it's my exit exams will be coming up in the next 2 years, but it feels like there's so much more to learn. And London is its own kettle of fish, so you're learning so many different things. So I'm not seeing the light just as of yet. We've still got a while, but it's exciting to know that I suppose that this is the last hurdle until I don't need to move around as much and actually get my final qualification. So that is quite nice.
I think
Thank you for that impressive introduction.
No worries. It's longer than most people I know, so don't worry. I think, to be honest, some of those concerns you just brought up are very similar concerns that a lot of doctors have as well, when their training is, dare I say it, so long, and it feels like that tunnel is just never ending, in effect. But well done. But
thank you.
Diving straight in, one of the big things we wanted to talk about in these podcasts was sort of the relationship between different healthcare professionals. And dare I say it, there is quite a lot of friendly banter between doctors and dentists, but I think most of that stems because we don't really know what each other do. I mean, there's a lot at university, a lot of medical school where it was, well, why is dentistry 5 years? And to be honest, I can't really answer that question myself, but we get a lot of problems in terms of from the general practice side where we have patients coming into us with dental related problems. And it's a bit far-fetched when we have patients who've taken quite a while to get through to us on the phones or make an appointment for us to then say to them, you need to make an appointment with your dentist. And if I was a patient, I'd get fed up. So what advice would you say is useful for us when we have patients presenting like that?
So I can appreciate that it can be quite frustrating when a patient has gone from pillar to post and then obviously come to yourselves. But I would say there's some things that obviously it's great for you to do in terms of screening. But then in other respects, the patient may need to go see a dentist because you can't necessarily do the interventions that they would require. So from a general dental practice side of things, from a general practitioner side of things, I would say initially for yourself, it's trying to understand the different ailments that could be occurring. So obviously, I believe most patients will probably present to you when they've got some sort of ache or pain from the tooth. So maybe differentiating what sort of pain it is. So is it a short pain that's occurred, or is it kind of a dull ache? So those are the two questions you could ask. When you have a sharp, short, sensitive pain, that's normally due to dentine sensitivity of the teeth, or maybe there could be loss of a filling material or something like that. And then in that respect, things like antibiotics would not really help the patient. They would need to go see a dentist to either replace that restoration or have toothpaste that may sort out the necessary sensitivity. But you'd want to, before prescribing those things, you would want to understand where that pain is coming from. So in that respect, I wouldn't advise antibiotics from your side of things. Sometimes a patient may come with a dental abscess or maybe pain from a back tooth. So they could be two different things. So when you have pericoronitis, that's pain from the most terminal tooth in the patient's mouth, and that can cause things like a very severe, dull, achy pain, which can cause limited mouth opening. If a patient presents to you, I would say, with limited mouth opening, then that would be maybe a collection of fluid has built up, or collection of pus has built up. So that would require antibiotics if they've got limited mouth opening, lymphadenopathy, or any sort of temperature. But if the patient presents with you with a swelling intraorally, but no other systemic problems, then I probably would say the best thing for them to do would be to see a dentist. So we can either incise and drain the infected area, or take out the most relevant tooth, or maybe start the process for a root canal filling. So from your side of things, I would say if they present with any sort of systemic problems, then I would give them antibiotics, so a high temperature, limited mouth opening, or swelling facially. But then other than that, actually antibiotics may not be the best thing for them, and some sort of dental intervention would be more necessary. And that's when I would say, actually, it would be it would be better for you to go see your dentist. And if they can't get a dentist, because obviously I think, is that where you would come to next? Is that what you were going to ask next?
Well, effectively, yes. I think a lot of the problems that come up are, we don't know much about the mouth, really. We can deal with sort of ulcers, we can deal with sort of potentially a dry mouth and certain things of the tongue. But if it's sort of dental related pain, I don't know. I think most average general practitioners will probably say that's probably infection. I would hazard a guess that not many of us would go ahead and treat with antibiotics, to be honest. I think in that respect, I think it's, my concern would be that we would be partially treating a patient, and there's always a fear that if I were to give something that might symptomatically help that patient, they may turn around and say, actually, I'm not going to bother seeing my dentist because the pain's gone away. But that's not alleviating the problem, is it?
No, exactly that. And then so in that respect, I understand it can be quite frustrating for the patient, because then they come direct to yourself. But I wouldn't be expecting you to do any sort of intervention inside a patient's mouth. And the best thing for the patient and in the patient's best interest would be them to go see their dentist. And that's the advice, I suppose, which you'd need to be providing in that respect.
What would you say to, because that leads on sort of one of the questions that we also have worries about, access to dentists. So again, I don't really know how this works, and I try to get my sort of dental checkup every 6 months, but we miss that sometimes. But I think a lot of the times patients turn around and say, I can't get an appointment with my dentist, but I'm in pain. And then how do we facilitate them getting a emergency dentist appointment, or is that even warranted at that time?
So, well, if a patient's in pain, it's definitely warranted that they see a dentist and get alleviated from that pain. And so where I would recommend the patient to go to is, if they don't have a regular dentist that they've been to, then I would probably recommend them to go onto the NHS Choices website, and they can enter the town that they're in, and they can look at the practices around that area that are accepting NHS patients at that current moment in time. And they can get registered with that dental practice and being seen as an emergency patient. Because of COVID, there's been quite a lot of backlog in seeing patients. Dentistry was shut down for a while at the beginning of the lockdowns last year. So it's just trying to, and then we've been restricted on what we've been able to do, due to the fact that a lot of our procedures are aerosol generating. Now things are getting back to normal, and we've got a certain amount of fallow time and things like that we need to follow. But due to this, we have had a backlog in the patients that we're seeing, and that's why some practices aren't accepting new patients. But there will always be a practice that will be accepting NHS patients. So it may not be the closest vicinity to that patient, but there will be something around there. If a patient has a problem that way, pardon?
I just said because they're accessible, essentially, aren't they?
Yeah, and they will be accessible. We have to make sure we can see emergency patients. But if a patient has a problem with the NHS Choices website or something like that, then I would or the dentist can't see them for in a week until a week's time or something, then I would recommend for the patient to ring 111, and they can direct them
Okay.
to an emergency dentist that would be open. But that would be an emergency dentist, and then
Right.
they would still need to be registered after that, and after that has been temporized or their pain has been resolved, they would still need to register with a dentist to be able to access dental
Okay.
treatment and get a proper form of treatment.
That's really interesting, actually, because I didn't actually know that you can go through NHS choices to find a dentist like that, and there's something that I probably will be advising my patients going forward. Just from a personal side of things, I've had patients recently come up, particularly in the midst of COVID, when telephone triage was a big part of consultations, and as you said, dentistry was heavily affected. I had a few patients saying to me that they basically couldn't afford dental care. And
Okay.
we obviously, from our side of things, much of what we do is free at the point of access. But I know very vaguely there's sort of banding when it comes to dental treatment.
Yeah.
I don't think any of us really have a clear understanding of how that actually works.
Okay.
So, I mean,
So yeah, no. So essentially, obviously, the NHS. We all know that the NHS has a limited amount of money. So it was in about the 1950s, I think, when they decided that they were going to make people pay for some form of dental treatment. So now, what the situation is that there is three bands for patients to pay for. So band one is for a checkup, to see the patient, to take relevant radiographs, and to do a clean and things like that. Then you have band two, which is when a patient may require, it would still encompass band one, so you're not having to pay for band one and band two. But that would be the
okay,
checkup, any relevant radiographs, and then that would be either for fillings or root canal treatment or extractions. And regardless of however many the patient needed, that would be all under band two. And then band three
okay,
is for more complex treatment, which requires the lab. So that would be if the patient needed dentures or if you needed a crown or something like that, and that's NHS treatment. Obviously, if you need an implant or things along that line, that's not covered under the NHS. So that would therefore be private treatment itself. But that is what the band
okay,
structure is. It's 1, 2, 3, and that band structure changes. So the prices change, um, and I think they've gone up slowly over the years. But it's not down to kind of the dentists who are doing that. It's down to the government increasing the prices essentially.
okay.
So
So
uh,
when a patient is actually at the, they finish their dental treatment, and they said, you have to pay £48 or whatever it is. Does that go to the practice?
so that money, the way it works is we're paid on a unit of dental activity basis. And the practice has a set number of units of dental activity that they need to do.
Right.
And then we are paid via those units of dental activity. So the money that the patient's paying is not going to the practice. It's we are paid via how much work we have done in according to the units of dental activity. So for a band
Okay.
one, we get 1 unit of activity. For a band two, we get 3 units of activity, and then it's so on and so forth for the different bands. So it's not the money
Okay.
that the patient pays comes direct to us at all, and we don't structure that payment either. That's all through um, whatever the government chooses in terms of what patients have to pay. And I know it can be quite frustrating, and there is those patients that are exempt. Um, so,
Yeah.
for example, free dental treatment is for patients under the age of 18 or patients under 19
Yeah.
and full-time education, those that are on pension credit guarantee, pregnant women and children under one, those that are on income support.
So
I'm
it's the
not
same
saying
stuff
that
on
the
the
whole entire list.
prescription stuff.
Yeah, but it's similar to what prescriptions have. And you can also get a
Yeah.
HC2 or HC3 certificate to give you partial exemption or full exemption, depending on how much you're paid. It's a means tested thing. So it's just,
Right. Okay.
you can get free access if you require it, or if you if you're qualified for it, essentially. Though what I would say, and definitely what I've spoken to my colleagues about, is some people that do get free dental treatment don't tick the exemption form in the correct manner, or they haven't got the correct access and they just tick it without actually having something, and then you would have to pay for your treatment and you can get a fine, because these things are looked at and looked into. So just make your patients aware of that, because
yeah, that's definitely a learning point,
there is free access for them.
It's definitely a learning point, because we are, it's something that relatively happens, relatively common, in the sense that patients come to us saying, A, I can't access my dentist, and B, I can't afford it. So now I could technically say, if it's not an emergency, of course, NHS choices 111. Have a look. If you don't pay for your prescriptions, in the simple terms, you probably are going to be paying for your dental treatment.
Yeah.
Okay. That's quite interesting. I think it's only fair for me to ask a question backwards as well. Is there anything that sort of comes across I understand you're quite a specialist in terms of what you do, but from a general dentistry side of things, and even from what you do, is there anything that you think, I could actually get more help from the patient's GP in terms of managing whatever's going on?
I suppose, because I was before this podcast, I was speaking to my colleagues about this, like, what would we want to learn from you, I suppose. And initially, we have quite a lot of patients who, we have patients who are medically compromised, may need antibiotics in terms of antibiotic prophylaxis, or may have cardiology problems, such as previous valve replacements or infective endocarditis, things like that. So there is some guidelines on what we can prescribe via NICE guidelines, but also we may just want some advice from our practitioner colleagues. So I suppose it's sometimes people aren't getting, haven't received replies from when they've sent letters to the GPs, just asking for advice on when to prescribe antibiotics or when not to prescribe antibiotics. So say, what would be the best way to go about that? Should we be asking yourselves? Should we be asking cardiology? Is there anything you want specifically in a letter when we speak to you about it?
I'd imagine, to be honest, a lot of the time we probably wouldn't be the people making the decision of whether specific to antibiotic prophylaxis is appropriate. I think you're probably referring to patients with valves, I'd imagine, or complex cardiological problems. More often than not, what I would advise is, if you were to write to us and just say, have you got the contact details for their cardiologist or their valve team, whom should be able to answer this question. But to bypass that, something that we often do is we ask our patients for the contact details, because they often have direct lines to secretaries or direct email addresses to certain people. And that may be good enough. So you could ask your patient, do you have access? Because most of the patients under the valve teams would stay under them for quite a period of time. They won't get discharged they will, but not as frequently as other conditions, for example, particularly if they're on anticoagulation and need ongoing monitoring. So because of that, they will often have a dedicated nurse or have a direct line to somebody where you just say, look, do you mind just contacting them and just saying, would this be appropriate to give you antibiotics, or what do we need to consider when we're managing you?
Okay. So basically ask the patients if they have access to, say, their cardiology team, rather than going through yourselves for information.
I wouldn't say don't contact us. It's probably useful to sort of, we probably need to be kept in the loop regardless. But I think if you need something done relatively quickly, to be honest, we're going to get a bunch of letters coming into our practice on a daily basis. That could be from hundreds, that could be thousands. And if there's a letter from a dentist saying, can we have the contact details for the cardiologist, we will get round to it. It just might not be the priority unless you say, this is urgent.
Okay. So in regards to letters, actually, so that's quite interesting. I had another question. Me, myself, I see patients on quite a longitudinal basis because I do orthodontics. So we see patients over a 2-year period. And we see them quite regularly, every 6 weeks. And we get and I treat mainly children. So I get a lot of patients who don't attend their appointments or miss their appointments because we are seeing them for such a long period of time. And I was speaking to recently to my safeguarding team about this, and they said we should make the GP aware of when our patients miss our appointments. But I can imagine from your side of things, if a lot of sometimes my patients don't come with their parents, they're at school, they forget to attend their appointments. And also in just specialist practice, they may not come to quite a few appointments in that 2-year period. When do you think it's the most relevant for us to be sending you letters? I can send you a letter every single time the patient doesn't turn up to an appointment. But I was when I spoke to my safeguarding team, we said maybe after the second DNA. We obviously you're getting bombarded with letters. I suppose the question is, when is it appropriate to make you aware of them missing appointments? I suppose.
Every time, in a nutshell.
Every time.
Because the reason for that, and that's a really good question, because I think that's a lot of, it could be a dentist like yourself saying, my child patient isn't attending an appointment. It could be a school nurse. It could be a specialist in whatever field. But at the end of the day, dental problems are often one of the first presentations for child neglect a lot of the time. And we know that. And I think every sort of trust, every sort of GP practice, and I'd imagine you guys as well from a dental viewpoint, will have a safeguarding policy when it comes to children. What we do locally, this might not report to everyone, but if a child patient has had 2 consecutive DNAs for specialist appointments, the onus is upon us as a healthcare team to then contact the patient's, parents or guardians to find out what's going on. Are they actually still in the area? Have they left the country? Is there any particular reason why they're not attending these appointments? And if there isn't a satisfiable reason, I would imagine that the safeguarding team will probably have a low threshold to get involved, because it might turn out that, yes, it's healthcare that's sort of involved at this point, but also now being neglected at school, where they're missing school on a frequent basis, then probably not attending their sort of school nurse appointments. And there might be an entire sort of picture that could be built. So every time, I would say, if you have a child under 16 that's not attending an appointment, we would expect a letter to say, this is a DNA, just to let you know, basically.
Okay. And we are more than happy to do that. I suppose we were just aware of how many letters you received and what the threshold should be, but I'm more than happy to send letters every single time.
Don't get me wrong. I think everyone will groan about paperwork. I think in a different respect, as long as there's a clear section on there to say GP actions or for us to do something or not, that's appropriate.
It's just to make you aware. To be honest, well. But obviously I have a safeguarding team within my hospital as well, and we have definitely I think it's necessary.
We certainly need to know. Definitely.
Okay, no, that's really helpful. We'll do it every time, and I'm more than happy with that.
No, as I said, I think there's probably a lot more sort of questions, I think, from a dental viewpoint that you probably want to know from us as medics, and vice versa as well. But I think just moving on away from the clinical side of things, when I outlined a lot of your sort of credentials to date so far, I think, you've been to sort of the Midlands, you're in Yorkshire, and then you're on the South Coast, and then now you're in London. This relates to doctors as well. And one of the big things about sort of postgraduate specialty training is relocation. And you're hundreds of miles away from home, from your friends and family, for years on end. How do you cope with that?
I suppose it kind of gets to being part of the job, which is interesting. I had never, especially doing dentistry, I'd never foreseen myself to go down the specialism pathway and to be moving from one place to another place. But I obviously wanted to advance my skill sets and just do something else and something a bit different. So what I would say is I got used to it. I got used to the different traveling to different places, and actually the excitement a new place can bring. It's very interesting to say, I've lived in Sheffield, I've been able to go to the Peak District, I've been able to explore around the north, and then go down and see the beauty of the South in England. I think from everywhere that you go and where you live, there's something new you can learn.
Yeah.
And actually,
Okay.
you can see it as a great opportunity rather than being just away from your friends and family. You see it as a okay, what can this place give me? What can I do around here outside of my academic life or my work life, which I can enjoy? And I love the outdoors,
Yeah.
and I love like the beach and water sports. So actually, the Southwest was a really, really great place to be, and I just had never realized how much I enjoyed it down there, and how much I would enjoy it down there, and would never have actually thought to go and explore the Southwest until I moved. So I
Okay.
think it was daunting going to all these different places. But what I would say to others who are doing the same thing, it's also a great opportunity to just
Okay.
explore and learn about other places.
Yeah.
So yeah, I'd say it's shaped me and it's made me grow, and I've learned a lot about myself, but
Yeah.
also a lot about the UK, which is quite nice. I made a lot of friends all over the place, which again is great.
Yeah.
So yeah, it's exciting to
I
go
think,
somewhere new.
yeah, I
And
would
just
agree with
being,
you in that respect. I think, yeah, as in, like, I think for me personally, like, I did much of my training sort of in the southeast, in London, in South London, in northeast London, down in Kent. I was quite lucky in the respect I didn't have to move too much, and I found that quite beneficial. But I would agree, it was a bit of a growing up experience when you're sort of moving from place to place. You have to settle down in different places. You have to sort of put down roots in different places. And as you said, making friends in different parts, and I think that's important. I think I would agree with you in terms of seeing it as an opportunity. What would you say to the people that who aren't so keen? Because I think dentistry works different from medics. It's in terms of when you apply for your first set of jobs, it's quite a national sort of application there, and you could, in theory, like medics, be sent anywhere across the country. What would you say to those who are very hesitant or very sort of homely in the sense that they don't want to leave what they're comfortable with?
so those that do well, I suppose. So to do what I've done and to do our vocational training is national recruitment, which is similar to medics, and then our dental core training and things like that again are national recruitment. So obviously it's dependent on what you want to do with your life, because as you're aware, you get ranked
Mm,
via national recruitment. Sorry, and so if you want to stay in one location, obviously you would rank that the highest,
mm,
and and obviously do the things to get you to that higher level to be on that
mm.
national recruitment scale to try and stay within the area you want to. What I would say is dentistry is a little bit smaller than medicine, so the jobs are a bit more dotted
Yeah,
around. And those that do get a job somewhere where they don't necessarily want to go, there is always next year. You don't need to rush.
yeah.
You don't need to.
Okay.
This is not a race. It's your life, and you can decide when you want to do things and at what point you want to do things.
Mm.
You're never forced into any decision because it's still your life.
It's the
But
journey, isn't it?
it's a journey, exactly. And regardless of how you get to the top of the tree, whatever your top is, you can go via a straight
Yeah.
ladder, or you can go via a jungle gym type approach, and it doesn't really matter.
Yeah.
And actually, that jungle
Yeah.
gym kind of lets you know a little bit more about yourself, and you get experiences outside of the hospital setting or outside of different settings, which you would never know and appreciate. I think everything builds you. So I would
Yeah.
say if you get a job in a place you don't necessarily want, how much do you want that job? But also think about all the other opportunities there are around for you, and think about actually, is
Yeah.
it beneficial to work in a different trust? Understand how different people work. Like, that's a huge thing I've noticed. There's massive differences with working in the Southwest and working in London in terms of their trust and in
Mm.
terms of their methodology. It's just very, very interesting to learn from different things, and actually, in a work environment, can broaden your skill set hugely.
Mm.
So I'd say don't rush. If you don't want to go, you don't want to go, because you also want to be happy. And
Yeah.
work is not everything. But there are so many things you can learn. So don't just look at it as in, oh, I just want to stay. Yes, it might be nerve-wracking, but actually there's a whole world that you don't know. So go
I'm
for
really
it
glad you said that, because a lot of those sort of lessons essentially could be life lessons as well, in the sense that I think you do have to push yourself out of your comfort zone a lot of the time, particularly when it comes to further training. You're going to have to be things that you are not comfortable with, and you do grow. And I think that sort of broader experience, because I think dentists and doctors as a whole, we're very sort of tunnel visioned in terms of what we want to do, how we get there, and that's just not going to that's not how it works. Full stop.
Yeah, that's not life.
Yeah, it's not life, is it?
You can't control everything, which is, I love to be able to control things. I'm a bit of a, what can I do? What's broken? But
believe me, I know the feeling.
You kind of realize as you get older, it's not life. And actually, would you want to control everything? Not necessarily so. Actually, ride with it, roll with it.
No, that's valuable advice. That's valuable advice. I think the other thing is, I was going to ask you, it's in terms of the experience you've had, I think you've done a lot of work sort of on the medical rotas as well, haven't you? Particularly in your sort of earlier career.
Yeah, so for my, it's interesting because in dentistry you need to obviously do dental core training, and that can be, it's a mixture of doing further specialities. So either you can work in a dental hospital doing, say, pediatrics, restorative, prosthodontics, so different aspects of dentistry. And you can do max fax as well, which is essentially working like an SHO doing things in a hospital ward setting, which obviously we're not really trained to do. So it was a bit, it was very, very interesting working in a hospital, which is what I did for my dental core training years. Essentially working like an FY1, FY2.
What sort of stories do you have from that time? Because that's obviously something that they probably didn't prepare you for in dental school.
Yeah, so we got a lot of we did get a lot of training in terms of basic medical skills. But what I was really fortunate to have was in the West Midlands, they had something called Dentist on the Ward, which kind of gave us a bit of an explanation of what might be asked of us. And this was looking at bloods, understanding the reading bloods, taking bloods. I was helped, but I had to catheterize people, which obviously is the opposite end of what I'm going to end up doing. So that was really interesting. I helped in a lot of max fax surgeries. It gave us, so which really, I saw a bicoronal flap being done, which was just amazing, and helped in that sort of a thing, helped in that place. We did a lot of, I was doing on calls and working nights where you'd see like medical emergencies in terms of people losing their airways, and we would obviously have to then do emergency tracheostomies. I myself didn't perform them, so don't worry, people out there that have got like massive facial swelling. It was the registrars, but we were kind of your baseline. We were your FY1, FY2. So I learned a lot about medically compromised patients. And like I said, it was a bit of a baptism of fire. I learned a lot in a very short period of time. And I appreciate that's probably what everyone's feel as well. You're going into a new environment, but obviously you've probably shadowed, whereas I hadn't. My role was really supported, which is what I appreciated. So my regs were amazing. They are they're duly qualified, so both medics and dentists. When you do maxillofacial surgery, and they've obviously been through the process of doing these dental core training jobs as well, and the consultants are aware of what you are like too. And actually also the med regs are quite supportive in that respect. When you're on nights and you have a medically compromised patient and you ring up your med reg and say, I'm max fax, I am a new dentist, please come and help. But so we do, obviously patient safety was never compromised in that respect, because there are lots of medics around you and lots of people who are supporting you. It just was a very, very different experience from me. And obviously,
I can't
I
imagine.
really, really enjoyed it. I loved it, actually.
I can't imagine just... It's okay for us in the sense that we go through 5 or 6 years at university and we know we're going to be catheterizing patients. We know we're going to be doing this sort of the grunt works on the wards and stuff. But for someone who's dentally trained to then be told they need to catheterize someone, just it doesn't make sense. I don't know why or how that would even come up. I don't know. Anyhow,
it's so obviously there was somebody there with you. They're kind of seeing if obviously with MaxFax, it's very, very long pathway, and it's most people are dentally qualified, then medically qualified, and going into it. So it kind of gives you a taste of what you can do in the MaxFax setting. It also gives us an understanding of working with medically compromised patients, and those patients you see in the GP that are like, actually, you're losing your airway, you need to go into hospital. So more complex dental issues. So we do have that baseline understanding, which say if you were covering, if medics were covering like MaxFax overnight, and they see patients with dental trauma coming in, or patients who have had mandibular fractures or like facial fractures, it normally all goes to MaxFax. So it's kind of that sort of thing we do have experience in. So yes, everything else was a bit of a baptism of fire, but you do have some things which you are comfortable with in that respect.
That's crazy. You probably have loads of stories when it comes to that sort of stuff, and a lot of insight in terms of how medics work on the wards from a very junior doctor point of view. But
actually, that's been hugely beneficial when undertaking specialist practice as well, and doing this post CCST work, because I work with people with a lot of facial deformities, and obviously they're having their bracework side of things, but they then have surgery to correct their facial deformities, essentially, and they are on the ward and they are being seen by patients. They are being seen in a hospital setting in that respect, in a ward-like setting. So they're having all their surgery. So I have a greater understanding of that, which is very cool.
That's crazy.
Why we go through that.
Right. That's a massive insight, actually. And to be honest, it's not something I would expect a dentist to come around and say that. I still can't get over the catheterizing thing, but I guess I have to. Anyway, I think, look, just to round this all up, there is one question that we do like asking every one of our guests when they appear on these episodes, and that is, what is the one piece of advice that you would give your younger self, at the beginning of your career, that you wish you would have known had you been in those shoes?
I would say to my younger self is, like I said to you, it's something I actually learned. So life is less of a straight ladder; it's more of a jungle gym, and you will learn so much from doing different things. And don't be so scared, and don't be so worried about it. Like, people are around there to support you and help, and have confidence in your ability, I would say. Everyone doesn't know everything, and everyone has their strengths and their weaknesses. So focus on what you can do and focus on your strengths rather than thinking, I don't know things. It's okay.
Amazing. I think that's advice that loads of people probably could benefit from, and I didn't know you were so philosophical. So, but anyway, Miesha, I just want to say a massive thank you for your time today. I know you're busy, and I know you've given a massive insight in terms of, from us, from general practitioners and doctors as a whole, what the world of dentistry is, and I'm hoping that we've sort of tried to cross some of those bridges that are difficult to cross often.
I hope it's helped. It's been really, really lovely talking to you as well, and kind of getting an understanding from your side of things too. Definitely.
No. Brilliant. Thank you. So there you have it. That's Miesha Virdi's words of wisdom today. And I hope you really enjoyed today's first episode of Dorky Docs Handover podcast. If you have any comments or any suggestions, please do so leave in the comments below. We are still a growing channel, so any sort of support will be beneficial. But if there's anything you guys want to see sort of in the episodes coming forward, please let us know. But otherwise, we'll see you in the next episode.
Thank you.